Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 490 of our pharmacotherapy series, which majors in ischemic and hemorrhagic stroke. We will continue discussing the case of patient SPC in part 489 of this pharmacotherapy series. My next question to you reads: how should SPC's acute hypertension be managed? Excessive hypertension may expose patients with intracerebral hemorrhage to elevated risk of hematoma expansion, neurologic deterioration, and worse outcomes. Lower blood pressures have been suggested to potentially worsen prognosis. However, this phenomenon is not as well documented as it is with ischemic stroke. Several studies have shown that rapid blood pressure reduction to a systolic blood pressure of less than 140 mm of mercury is safe in patients with intracerebral hemorrhage presenting with hypertension. Additionally, studies suggest that aggressive acute blood pressure control can improve functional outcomes and may be associated with a trend toward a reduction in death. It is important to note that patients presenting with systolic blood pressures above 220 mm of mercury and those with very severe intracerebral hemorrhages have not been well represented in studies. Based on these studies, current guidelines suggest that lowering systolic blood pressure to less than 140 mm of mercury in patients presenting with a systolic blood pressure 150 to 220 mm of mercury and no contraindications to antihypertensive therapy is safe and may improve outcomes. In patients presenting with a systolic blood pressure greater than 220 mm of mercury, it is recommended to initiate aggressive antihypertensive therapy with an IV infusion and to carefully monitor the patient. Nicardipine and labetalol are most commonly used antihypertensive agents in patients with intracerebral hemorrhage, but hydralazine, nitroprusside, or nitroglycerin may be considered depending on the clinical situation. If labetalol is used to control acute blood pressure, it should be administered as IV boluses, potentially in combination with an IV infusion. Nicardipine is only administered as an IV infusion. SPC's blood pressure exceeds 150 mm of mercury, so IV antihypertensive therapy is indicated. It would be appropriate to initiate an IV nicardipine infusion at 5 mg per hour and titrate every 5 minutes to achieve a systolic blood pressure of less than 140 mm of mercury in SPC. Hours after admission, SPC's mental status worsens, likely because of severely elevated intracranial pressures. So my next question to you reads: what therapy should SPC receive for his elevated intracranial pressure? Elevated intracranial pressure refers to excessive pressure inside the intracranial vault, and may occur in patients with severe hemorrhagic and ischemic strokes as well as in those suffering from traumatic brain injury, brain tumors, hydrocephalus, and hepatic encephalopathy. It can lead to brain hypoxemia and cause herniation. SPC's worsened mental status may be consistent with elevated intracranial pressure. Other symptoms of elevated intracranial pressure include headache, vomiting, cranial nerve palsies, and the combination of bradycardia, respiratory depression, and hypertension. In patients with neurologic emergencies, such as SPC, hypertonic fluids such as dextrose 5% in water should be avoided in favor of isotonic fluids such as 0.9% sodium chloride, normal saline, and lactated ringers because hypertonic fluids can exacerbate cerebral edema and worsen intracranial pressure. When considering fluids patients are receiving, it is important to evaluate both maintenance fluids patients are getting and the fluids in which IV medications are diluted. In patients with elevated intracranial pressures, IV medications should be diluted in 0.9% sodium chloride rather than dextrose 5% in water or other hypertonic fluids whenever possible. Treatment of elevated intracranial pressure involves patient care measures, pharmacotherapy, and surgical interventions. First, the head of the bed should be elevated to at least 30 degrees once it is clear that SPC is not hypovolemic in order to minimize blood and fluid accumulation in the brain. Hyperventilation, increasing the patient's respiratory rate and/or the volume of air he breathes with each respiration, with a partial pressure of arterial carbon dioxide goal of less than 30 mm of mercury may be considered for a very short time in SPC until other interventions can be implemented. Hyperventilation should not be continued long-term because it can compromise cerebral blood flow. SPC should receive aggressive analgesic medications, such as fentanyl and morphine. Sedatives, such as propofol, should also be administered. Hyperosmolar agents, including intravenous mannitol, dosed at 0.25 to 1 gram per kilogram every 4 to 6 hours, or hypertonic sodium chloride may be considered to establish an osmotic gradient that can facilitate the movement of fluid out of the brain, thus reducing intracranial pressure. Clinicians may place an intracranial pressure monitor or utilize neurologic exams to guide treatment with hyperosmolar agents. If an intracranial pressure monitor is used, hyperosmolar therapy would be indicated to maintain an intracranial pressure of less than 20 mm of mercury, while if an intracranial pressure monitor is not utilized, a worsening in neurologic exam consistent with elevated intracranial pressure would warrant therapy. If SPC continues to exhibit elevated intracranial pressures after hyperosmolar and aggressive analgesia and sedation, a continuous infusion of a neuromuscular blocking agent should be administered. Last-line measures that may be considered include use of a barbiturate coma. In patients who develop hydrocephalus because of an intracerebral hemorrhage or another condition, a ventriculostomy may be employed. A ventriculostomy is a surgically placed drain that resides in the ventricle and is used to drain CSF. Finally, open craniotomy, or removal of a portion of the skull, in the area of edema, may be considered in highly selected situations. However, the efficacy of this approach is questionable in many patients. The next question reads, what other ancillary therapies may be appropriate for SPC? SPC may benefit from the following. 1. Maintenance of normothermia with acetaminophen if he develops a fever. and 2. Avoiding hypoglycemia or excessive hyperglycemia. Although the clinical benefit of antipyretic therapy has not been clearly established in intracerebral hemorrhage, fever is associated with a worse prognosis. It is recommended that SPC's body temperature should be monitored and acetaminophen may be administered to achieve normothermia. Studies evaluating mild hypothermia are ongoing. Both hypoglycemia and hyperglycemia should be avoided in hemorrhagic stroke. Hypoglycemia can directly lead to neurologic injury, while hyperglycemia is associated with worsened neurologic outcome from stroke. Current guidelines recommend avoiding both hypoglycemia and hyperglycemia, but do not suggest a specific blood glucose range. Considering that his blood glucose is markedly elevated, SPC should be initiated on an insulin regimen in accordance with institutional policies. Seizures can complicate approximately 16% of all strokes and may be difficult to observe because they are often non-convulsive. However, because studies of prophylactic antiepileptic therapy have failed to demonstrate consistent benefit and have sometimes indicated harm, current guidelines do not recommend routine seizure prophylaxis. Antiepileptic therapy should be initiated promptly if a patient develops seizures during or after the development of an intracerebral hemorrhage. The next question reads: what secondary prevention strategies should be recommended for SPC after he recovers from his intracerebral hemorrhage? For SPC and any patient who has suffered an intracerebral hemorrhage, key modifiable risk factors that should be addressed upon stabilization include maintaining blood pressure at less than 130 systolic 80 diastolic, smoking cessation, treating sleep apnea, avoiding excessive alcohol use, and abstaining from cocaine and other illicit drugs. The next case reads: patient JAK has had a stroke and has received appropriate acute care. He is ready to be discharged from the hospital, but still has trouble walking, talking, and performing activities of daily living. So my question to you reads: for patients who require rehabilitative care after hospital treatment of an ischemic or hemorrhagic stroke, what interventions will aid their recovery? Patients who have suffered ischemic and hemorrhagic strokes often require long-term rehabilitation after their acute treatment. Rehabilitation is directed at managing daily functions, enhancing existing neurologic function, and attempting to regain lost function. Considerations for daily functions include activities of daily living and bowel and bladder management through balanced pharmacologic interventions. Efforts should be made to allow patients to function independently with activities of daily living and manage the psychologic effects of stroke. Enhancement of current neurologic function and minimizing depression includes elimination of drugs that may compromise patients' memory and mental function. These include benzodiazepines, major tranquilizers, and sedating antiepileptic drugs. Localized spasticity is a common complication after strokes. Spasticity affecting a single limb frequently responds to regional motor nerve blocks with botulinum toxin. Aggressive physical therapy is also essential to the management of spasticity. Systemic antispasticity agents such as diazepam, baclofen, or dantrolene sodium are not used routinely because of the risk for toxicity. They are used only when spasticity involves multiple parts of the body or is unresponsive to other therapies. Other less common impediments to patients' recovery after stroke include decubitus ulcers, hypocalcemia, and heterotopic ossification, e.g., the laying down and calcification of a bone matrix in muscles surrounding major joints. Prevention through meticulous skincare is the key to the management of pressure ulcers. Mobilizing patients as soon as possible after stroke can prevent hypocalcemia and heterotopic ossification. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 491.